Hi, I'm Grace from Terumo, and I'm here today to talk to you about the TR band. The TR band is a radial compression device that will be used after a heart cath procedure to close the radial artery. So a couple of features to note about the TR band. We do have a new applicator port and a new syringe tip. This is still just a slip tip syringe. There is no lower lock mechanism here. And you want to make sure that throughout the whole process of application and removal, we are holding the back of the syringe because the balloons are pressurized, and when we attach the syringe to the applicator piece here, we will have kickback and the air will kick back out of the balloons. So just to keep that in mind throughout the process. But I'm going to walk through the entire application and removal process from the very beginning. Can I have your wrist, please? This one. Most heart caths are done through the right arm. So we've just finished up our heart cath, and I'm going to place the TR band wristwatch tight, so it should not be moving around on the wrist. Where our green dot is located 2 to 3 millimeters up the arm from the entry site on the wrist. So I have marked 2 marks on my wrist. This mark here is supposed to be the entry site on the wrist, and this mark here would represent our entry site in the artery. Because we are entering the radial artery at a 45-degree angle with our needle and our sheath, the actual hole in the artery will not be aligned with the hole in the skin. That is important to keep in mind and important for the placement of the TR band. We want our green dot to be over the hole in the artery, not the hole in the skin. So the next thing that I will do is remove my sheath most of the way out before adding air, and then I will inject my air. So we suggest to start with 18 cc's of air in the syringe, and I will inject all 18 cc's while simultaneously removing the sheath from the artery so that I complete the insertion of the air at the exact same time that I complete the removal of the sheath. Then I will slowly remove the air from the balloons 1 cc at a time, keeping an eye on the entry site on the wrist, just distal to our green locator dot. And when I see a flash of blood, I will put 2 to 3 cc's back in, make sure that that bleeding has stopped, and detach. At this point, we'll take note of how much air is remaining in the band, and this patient is good to go to recovery. So for recovery, we have a set amount of time to wait before removing air for a diagnostic procedure and a set amount of time before removing air for an interventional procedure, just to make sure that the heparin used in an intervention is out of the system and we have time for that clot to form. What are your times that you use for your diagnostics and your interventions?
Anything with 50 units per kg, we're going to wait at least 60 minutes. Anything greater than that, you're going to wait 120 minutes, so 2 hours.
Perfect. Then what we'll do is remove air every 10 to 15 minutes until the band is empty. Your protocol suggests 1 to 5 cc's every 10 to 15 minutes until the band is empty. Our indication is 2 to 3 cc's every 15 minutes until the band is empty. And then once the band is completely empty, we'll wait another 15 minutes before actually removing the band from the wrist, just to make sure that we have enough time for this to heal before we actually disrupt the area and remove the band. And the most gentle way to remove the band is by first undoing the Velcro from the back of the wrist, and then fully inflating our syringe, attaching and inflating the balloon. You'll see that popped off really nice and gently, so it's not disrupting the clot. And at any time during the air removal process, you do see a flash of blood at the entry site or any bleeding in the area, you'll want to re-inject the 2 to 3 cc's of air that you just removed and wait 30 minutes before continuing the air removal process. And if that is not an immediate flash of blood, if you see no bleeding after your air removal, you walk away and you come back 10 minutes later and you do have some blood seeping out of the entry site, you'll want to add 2 to 3 cc's and then wait 30 minutes before continuing the air removal process. Anything else you would like to add?
Yes, I do. My name is Bailey Mayer. I am currently one of the clinical educators who specializes with critical care here for Avita. Grace has been great in talking all things device related per the company. Let's go ahead and talk about what's Avita specific things. Similar, basically the same, but how we're gonna really function on the floor for you. That's what we wanna talk about, right? So let's start from the point of cath lab coming up with the patient. Grace has already demonstrated how this device is put on. There are a couple of situations we'll talk about here in a few minutes where maybe you do need to apply this. Sheath has been taken out, patient has come up to the floor, and they already have their TR band in place for you. So first thing we're gonna do, bedside report, right? Because we do bedside report every single time, okay? So nurse to nurse handoff, we're gonna ask them a couple of pertinent questions. Typically our cath lab team is really, really good about putting notes in with specifics of how much air has been put into the TR band when hemostasis was achieved as well. We do want to be aware of how much heparin the patient has received. When in doubt, wait the 2 hours, but keep in mind, per Avita policy, 50 units per kg or less, which 50 is what it's going to be. 60 minutes is appropriate before you start pulling air out. Anything more than that, we wait a full 122 hours, because that's how math works, before we start taking air out. So again, when in doubt, just wait the full 2 hours. Nothing wrong with that. So we've got those three things, right? Bedside reports happening. We're talking about any possible interventions. Was this diagnostic? Families at bedside. Everybody's involved. We want to know, one more time, how much air? What time this has happened? How much heparin, right? Right. So let's say we've done the things. We are now going to assess our patient, because that is the next thing. Before they leave, we want to make sure we're all on the same page as far as the condition of the patient when they arrive to the floor. So a couple of things we want to really, really keep in mind. Specific assessments are kind of unchanging regardless of what devices are involved, right? So we've used a radial artery in this scenario. Ulnar arteries can be used, but in this scenario, we're going to talk radial, okay? And we've went up, we've done all of the things. So we have this device that's adding compression to our wrist, right? The point of it is to help prevent unnecessary bleeding, right? So we're gonna do neurovascular assessments. Same things that always are involved with that. Per policy, one of the first things that we're gonna do during our bedside report and while we're assessing the patient, we're gonna make sure that we have an SpO2 probe on either the index or the thumb finger of the affected wrist. Again, typically radial, typically that is going to be on your right hand. It can be on your left, so whichever one has the device is where we're going to put it. Yeah, sounds like a good idea, right? So we've got that on. We're going to continue to educate the patient during these assessments, because why would we not make sure we're all on the same page, right? We're going to tell them increased numbness and tingling. If you feel something warm or sticky coming down, you're going to call for help, because we don't want them sitting there with the bleed, right? You can't be in the room nonstop when you've got other patients you're caring for. Following that, we are going to make sure that we have our actual syringe, our slip tip syringe, as Grace mentioned before, to remove the air. This device is not available to you on the floor anywhere. If this were to get lost or damaged, you would have to call your PCC, who would then have to go get a whole kit just for this one device. Now, as Grace said, contaminated. This is contaminated. This has been on a sterile field. Gloves every single time, which is just good practice, right? When we're going in a room, hand sanitizer, making sure we're taking care of patients and ourselves. So we're also going to make sure we have this to take care of this. We're going to look at the actual site. Do we have a lot of bleeding? Anything like that? A little bit of blood is kind of expected, because when cath lab did put this band on, they put air in, right, until they saw blood, and then added a little bit extra, and all was well. I'm sorry, they removed, and then when they saw blood, they added a little extra. All was well as they were pulling that sheath out. So we're going to double check the site, make sure everything is positioned the way that it should be. Additionally, we're going to look around the forearm, make sure that we don't have any crazy hematomas that are forming under the skin. Okay, so that's really what we're going to do before the patient leaves. Are they fall risk? We're going to do all of those other things that we typically do, call light, all of that. But really TR band specific, that's what we want to do. Be sure when you're doing your checks on this patient that blood pressure cuff is not on the affected arm, okay? Blood pressure cuffs, IVs, any lab draws, the goal is to protect this arm the most that we can for 24 to 48 hours, okay? Treat it like it's broke, I think is exactly what Grace is phrasing was. So we're gonna follow that, right? And then we're gonna go do whatever we need to do. So now, we got an intervention, so we're gonna say we waited the full 2 hours, okay? Removing air per policy is different but the same from what the reps recommend. Anything from 1 to 5 of air is what we want here at Avita, every 10 to 15. So let's just say 15. We use 15-minute increments for so many other things here. That's a good place to start, right? So we've waited the full, typically there's 12 to 15 of air in here anyway. We did the full 2 hours, we're gonna go ahead and start removing air. If in the process of removing air, you don't have that thumb on that stopper, it's automatically gonna kick back and then you're gonna remove too much air and have unnecessary bleeding, right? So before you remove any air, make sure that thumb is there. We're gonna attach and stop anything that's too quick and remove appropriately. We're gonna sit there, we're gonna wait, we're gonna make sure. Okay, if we do notice a little bit of bleeding, what are we gonna do? We're gonna put the air back in, right? And then if it continues to bleed, it's always appropriate to add a little bit extra, but there's not really like a set policy limit on that. So if you get into a situation, which we all know it's gonna happen in the middle of the night when you're on your own and you haven't seen a 2-year band in a while, and you have a bunch of bleeding and it's not stopping even with that additional air added on. At that point, manual pressure is always gonna be preferred. We're not doubling up, we're not doing those things. I believe Grace did speak on that a little bit. But just keep that in mind, okay? Manual pressure is your friend, okay? And with that manual pressure, this is a sheath access, so we go 2 finger breaths-ish above where the incision is that we see on the skin, and we're gonna manually hold. That is a scenario where you may have to put this band back on then, right? So everything that Grace said before is still relevant, just minus the sheath removal for our team if we have to put it back on. I've personally had a situation where somebody was confused. When I went into the room, blood is everywhere because, you know, the patient, for them it looked like a not super fashionable watch, I guess, and they decided it was time to take it off and they were not ready. All of that air was gone. So it was manual pressure, right? Stabilize the patient. If we need to put the device on, we can. If we have to put a dresser or pressure dressing on, that would also be appropriate for policy. Make sure we're contacting the provider and letting him know. Make sure that we also are outlining any underlying hematomas. And with that, after we have achieved the bleed stopping, right? That is the goal. We don't want to just like outline, sit, watch. We want to make sure we are intervening where is necessary and then updating the provider appropriately when the patient is safe, okay? So those are really like the bigger complications you could see. Our policy does say that you can remove all of the air at one time as long as you're closely monitoring the patient, and we've waited the appropriate amount of time based on their heparin. I have tried it, it's not really my favorite, so I am more like the 1 to 5 girl. You're not wrong for doing that. That's just what most of us seem to be doing here. So that's kind of the process of removing it, trying to make sure I've caught everything. So let's talk about actually taking the band off. So we removed all of our air, all is well. It is not written specifically in our policy that you have to wait 15 minutes before removing the band. I do know that's what the device manufacturers are recommending. So we're gonna wait before you go into the room to actually take the device off. All the air's out, we've waited the 15 minutes, now it's time to try to give her, let's say her for the patient's sake, her wrist back. We are going to remind her of a couple things. Treat it like it's broke, right? We're still not doing any excessive bending. We're still not lifting anything crazy. Goal is to protect it from blood pressures. We still don't want IV sticks, all of that. If there's the increased numbness and tingling, if there's the warm sticky feeling, if any of that exists, encourage your patient still to call for you. But nice little trick. I'm not sure if Grace did it in her demo, so we're gonna do what she did, where that's on there, and we have our 2x2 and our Tegaderm ready, because that is what we're going to dress this with after it's removed per Avita policy. So you're gonna inflate. It's gonna lift that off for you. Sorry, I'm not doing it as graceful. And then you are going to use your 2x2 and your Tegaderm on top, continuing to monitor that site and document appropriately. Okay. We do have a tip sheet for EPIC specific documentation that we expect here at Avita. we want you to add the LDA, and there's a couple of steps for that. So we do have that available to you. Additionally, removal of the actual device has to be spelled out in our significant event box so you can free text in. We just never want it to be a situation where there's any possible legalities that get involved. Not only did we remove the air, the actual device has been removed from the patient, a tegaderm has been applied with a 2x2 underneath it. Those are really the most important things. As always, if you have any questions or concerns, reach out to your coworkers. We're never on an island. We don't want you guys to feel that way. Also, your PCC is a great resource, and we love to teach, so definitely call education. And we are here for you. So we have these little sheets that are available. They've been sent to management as well, so that if you do have anything where, oh my goodness, I haven't seen a TR band and I haven't really thought about it for quite some time, it's a great resource just to break down the nitty gritty. This doesn't cover every single thing that could happen, but just for a brief reminder, this really is a good resource for that. We also have on the back the management specific things, possible complications and things we really want people to do, and a good visual reference just to remind you of what the sheet is actually doing and where that's located in regards to how the TR band is placed. The very last page, who doesn't love a screenshot? Epic's updating all the time, so we'll try to do what we can to keep these relevant for you guys. So things are changing, but it can be a little daunting adding the LDA in. So this is just a good step-by-step on how we're going to do that. And as always, any questions, we're your girls for that.